Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank the following Keystone funding partners for their ongoing contributions that support all of our programs and activities: the Stollery Children's Hospital Foundation, BC Children's Hospital Foundation, the Children's Hospital at London Health Sciences Centre, the Alberta Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and Holland Bloorview Kids Rehabilitation Hospital. We would also like to thank the organizations that provide funding for our knowledge translation activities, which includes this Spark Live webinar series, the Spark Conversations blog, and the Knowledge Exchange Network. To learn more about Children's Healthcare Canada, you can go to our website, follow us on Twitter or Facebook, or you can sign up for our weekly Spark newsletter at childrenshealthcarecanada.ca/email, where you will learn about upcoming events, read the latest posts from our blog, and other exciting news and events from across the child and youth healthcare community. All right, hello everyone. I'm Doug Maynard, Associate Director at Children's Healthcare Canada, and welcome back to our webinar series, or should I say welcome to our first episode of Spark Live. Yes, you've all heard that correctly. For those of you who were at the CAFC conference in Edmonton almost exactly a month ago now, you would have been on hand to hear our incoming board chair, Dr. Maureen O'Donnell, and our CEO, Emily Grunwald, present our new strategic plan, part of which included a full rebranding of our organization, and that included a name change. So after 17 years as CAFC, we're now called Children's Healthcare Canada. You may have seen that on our blog or on our website already, but for those of you who this is new for, you are still in the right place. And our knowledge mobilization program, our webinar series, which was called CAFC Presents, is now called, our full program is called Spark. With the intent being to curate and convene and showcase excellence and best practices from across the child and youth healthcare community to spark conversation, ideas, and action. So since these presentations are live, our webinar series is Spark Live, and you'll also notice our blog is now Spark Conversations, and more to come underneath the Spark program as well. So since we are live, I do want to remind everyone that once we start the webinar, you do have the opportunity to type questions into the question box at any time. We will check for questions throughout the session, so don't feel you need to wait until the end of the presentation before you type them in. Go ahead and type them in as you think of them. And also feel free to share your thoughts on Twitter, and be sure to tag us at ChildHealthCan. All right, so today we're going to be talking about integrating children's mental health services in New Brunswick. And this really is a great topic to introduce on the heels of this new strategy and new name change for our organization, because part of that motivation for the change was for CAFC to continue its transformation from the association representing children's hospitals to recognizing and accommodating a child and youth health community that reflects the diverse spectrum of care providers and care settings and all the different parts of our community that play a role in providing health services to children. So today it's going to be a real great opportunity to talk about what's happening in New Brunswick in this regard, about integrating services across their province. So with us today, it's my pleasure to welcome Dr. Bill Morrison, who is a clinical psychologist with an advanced graduate degrees in both educational foundations and psychology. In addition to his 25 years of clinical practice, he has had extensive experience in the development and implementation of health and education services for children and adults across several Canadian provinces. And joining Dr. Morrison, we have Dr. Patricia Peterson, who holds a doctoral degree in education and is currently a faculty member at the University of New Brunswick. And she's the co-executive director of the university's Health and Education Research Group. She's also currently the president of the Learning Disabilities Association of New Brunswick and has authored the Positive Mental Health Toolkit, which is a series of online ebooks used by schools across Canada. So it's my pleasure to hand the virtual podium over to Bill and Patty. Over to you guys.
Thank you, Doug. I'm just making sure we're not echoing too much. Hopefully this is okay.
No, you sound great. Yeah.
Great. So Bill and I are pleased to be here and to be able to share with you today a little bit about our experiences here in New Brunswick, and going forward, we're actually starting to see some really positive change and some interest across the country as well in integrating children's mental health services. Look, here we go. So today what we'll be doing is talking a little bit about our experiences here in New Brunswick initially with ISD, or integrated service delivery, and the rationale for ISD. for children and youth. So the why of it, what were the challenges that led to a need for systematic change in the way we deliver mental health services here in our province. We'll look at some of the processes that were involved in developing and implementing the ISD framework. We're going to look at the guiding principles and the key elements that are part of the framework. We'll share some of the evidence of transformation that's come out of the formal evaluation process to date. And we will end with discussing the creation of ISD's interdisciplinary standards of practice and have some time for questions at the end. Just a little bit on our background. Going back to 2009, the government of New Brunswick was inundated with some very serious reports of traumatic events and challenges with children in care related to mental health and the way that we dealt with mental health issues and challenges among our youth. When those reports came through, there was clearly a recognition across the province for a need of the need for real transformation. And we throw around the term paradigm shift quite loosely, but it's truly what it was at that point for us here in New Brunswick. We had lost children in care. We were incarcerating children with mental health concerns. There were so many things happening that our kids weren't falling into gaps. They were falling into chasms in our system. And so it was time to shift from that system-centric mental health service approach towards a more unified view that put youth, families, children at the center of our service delivery structures. And you know, we often talk about having child and youth and family-centered services, but having the capacity to put the details to that, the how-to, really had eluded us for a long time in our province. We came to a point where we realized that it wasn't just bits and pieces of change we needed. We needed to put everything on the table to move forward, to truly have a child and youth-centered approach. And when we did that, all of those barriers that you face, the systemic barriers related to profession, to scope of practice, to departmental silos, all of those, at that point, we made a commitment in this province to view those through the lens of being focused on the individual and wrapping services around as opposed to making families go out and access services on their own that were sometimes hard to navigate. So a little bit of the background, those four reports, or the four key reports that came in at that point by 2009 were Connecting Care and Challenge, Tapping Our Human Potential. This in New Brunswick was known as the McKay Report, and it talked about inclusion in our education system and what we needed to be looking at in New Brunswick in order to be fully inclusive and meaningfully inclusive of students and children and youth with all manner of challenges, strengths, gifts, the whole package. Connecting the Dots came from our Ombudsman and Child and Youth Advocate, and this was an eye-opening report that talked about the condition of youth at risk and youth with complex needs in New Brunswick. What was our process? Where did they go? How did we design treatment? How did we support? And what we found was a very disjointed and ineffective system for working around youth mental health. The Ashley Smith report was a heartbreaker for us in New Brunswick and for many across the country who followed Ashley's experiences of incarceration and mental health treatment and supports that did not truly support. And Ashley was a young lady who actually died in prison in Ontario by her own hand. And the story is one that we never want to forget. In fact, the provincial director of ISD at the time this was implemented said that every time he felt that there were barriers that couldn't be overcome, he went back and flipped through Connecting the Dots or Ashley Smith's report to remind him of why this was paramount. And of course, also we had a new mental health care system report that came out, the McKay report in 2009. So when we looked at all of those together, there was certainly a need to do something that wiped the slate clean and started over with the children and youth at the center. Bill and I were contacted at that point to write the initial ISD framework. What could it look like if we were actually willing to see systemic change? And we started with that without perhaps a whole lot of confidence that it would ever see fruition because the changes were sweeping. But we'll walk you through what that process has looked like over the last several years. Very quickly, New Brunswick, as you know, is a small province. We have about 750,000 people in the province. Most of the area of our province is rural. We do have some very geographically isolated regions, islands, and others that traditionally have received really very few services related to mental health because of transportation, because of the challenges of getting to those individuals. And of course, our system at the time of the beginning of ISD meant that families needed to travel to access services. And of course, attrition rates were high, transportation challenges were high. As of December 2017, we have, as part of our provincial makeup, of over 16,000 First Nations people, almost 10,000 of those living on reserve and 6,400 living off reserve. So that represents about 2% of our population, and certainly also represents the need for cultural literacy and sensitivity in how we engage and respect the voice of and co-create with our First Nations brothers and sisters. We are also the only officially bilingual province, having distinct francophone and anglophone regions, and our cities, our major city centers, are both French and English. So the challenges related to having to create everything that we created in both official languages certainly added to the contextual considerations. So some of those challenges that we were facing in New Brunswick that led us to an openness to sweeping change were we had so many children, youth and families with complex needs. There was a lack of coordination of our services. Intervention planning happened in silos from one department, one service, one school to another. We weren't very good at that point of matching service intensity to level of need. For example, if a student in school would begin to have mental health concerns or emerging problems in that area, often there was an immediate referral out of the school system to mental health. There were wait lists. Services were provided to that individual outside of the school context. And so everything was happening apart from the child's day-to-day normal experiences. Kids were having to participate in families in multiple intake, assessment, case management plan processes. There was no cohesion or coordination in the way that happened. So you could have children, and in fact we did have many youth with up to 8 existing files in different areas of the system, mental health and education, certainly in our regional health authorities. And even if a child or a youth would become in conflict with the law, there may be a court-ordered assessment. The child would be sent for another assessment, and nobody would know that child had already completed a WIS or had a psych ed assessment, to the point where we had too many kids sitting down to do a WIS with a clinician who thought this was a first-time procedure, and the child would say, oh, the one with the blocks, awesome, let's do that one again. We had no way of communicating. Privacy and information sharing systems did not allow us to communicate the holistic experience of a child. Certainly difficulties for families in navigating all of those multiple service systems. The impact of some families' negative experience with formalized services. So for many families, when they're going to seek help and it's suggested that perhaps they contact social development, for example, to them that means child protection. To them that means crisis and risk of losing a child, and all of these sort of former negative experience come to bear, which meant that many families were not seeking support because of how challenging and how threatening that experience felt to them. And then the transportation issue as well, especially in a rural province like this, where most of our areas of the province would necessitate families having to travel some distance in order to access service. Quickly, just a few other challenges. We were working in silos. Our government departments did not have a collaborative approach or the opportunity to share information or consult with each other regarding specific cases. When families have wait times and wait lists and attrition for meetings and appointments, you see an escalation of emotional and behavioral features. So when those needs go unmet, things begin to escalate. So sometimes before there was an intervention put in place, you would see an escalated level of need or a more severe type of intervention that was necessary. The lack of voice of children, youth, and families. Services were things in some families' perception that were done to them, that they were not necessarily part of, and having the opportunity to use their voice and to talk about their experiences and to collaborate on what would work best with their family did not exist at that point. And finally, transition planning, those step-down approaches that would bring kids from the more intensive services they were undergoing in for one department back to their school or community context were often left unaddressed. We just hoped that when they went back, they would have learned some nice lessons and be able to apply and generalize those. But of course, that didn't happen very often. We have to be intentional about our transition and step-down approaches to reintegrate and re-welcome our kids back to their school and communities. So, little parent story, we use these throughout a document we created for the Graham Beck Foundation this year, just to highlight some of the voices of families and their experiences. So prior to the integration of services in New Brunswick, this was the story of one family very quickly. I can't tell you how many times we've taken our daughter to the hospital when she doesn't want to live and we're not sure what she will do. We have to call the police. And every time we end up in emergency, we tell our story once, maybe two, maybe three times during our time at emergency. We finally meet with a psychiatrist. We get a referral to mental health after a week or so. There's an initial assessment. We're placed on a waiting list. As parents, we seem to go in circles. We're not sure what door to knock on, and we've hired private counselors, which lasts for a time. When we talk about needing to work with the school or even to plan her free time in the community, there seem to be no connections. How do you make people work together? How do you get a starting point? At this point, we're still seeking out services, but nothing seems to last very long.
Great. I'm going to continue on and talk. Patty said a wonderful background, the context of mental health services, departmental services, and responding to the needs, complex needs. So I want to talk a little bit about how we got started. Certainly, as Patty mentioned, it was the 4 key reports that had a series of recommendations. And when we looked at those, approximately 2/3 of the recommendations suggested greater cohesion and integration of services working together. Having moved from actually as a director in the Department of Health with the youth treatment program, I came to the University of New Brunswick, and Patty joined me there later. And we were first engaged and carried out a fairly significant literature review on evidence-informed practices that looked at systems working together, integration of services. And this would be 2008. And then, of course, we reviewed the government documents and contextually what seemed to be the needs, as mentioned in the previous reports. The other thing was to engage people to talk about what they saw as needs, the strengths that we currently have. So there was a period of engagement, and finally there was a development of a framework for moving forward with integration of services. And the name ISD kind of stuck because that's what we started with. But I want to give you a little bit of a timeline of events so you can see that it goes back more than a decade. We're back from 1995 to 2005. We had the youth treatment program, which was an initiative of 4 departments where we set together across the province for children with emotional behavioral concerns, about 14 teams. And these teams would come together collaboratively to do, for cases that really were more complex from our regions, to plan and develop strategies. And then, of course, people would go back to their departments, and we would attempt to work together collaboratively, but still mandates, eligibility for services, limits of budgets, scope of what practice, and so on. There was a lot of different things that really we got started, but in many cases didn't carry through, weren't able to follow through, partly, in a great part, because of systemic issues. In 2008 to 10, we did our initial research, and finally a framework was developed and launched in 2010 with 2 demonstration sites, which was evaluated. We were part, through the University of New Brunswick, of the development of the framework and conceptualization. as well as setting in place the implementation and initial evaluation design. The University of Moncton, under the leadership of Jimmy Burke, carried out the evaluation, and that evaluation, probably around 2014-15, was reviewed, and we've had changes of government. And in 2017, the decision was made to move to a full implementation. What I'm going to do is take you through really the nuts and bolts of ISD in about 10 minutes, and it'll give you an overview of the direction. First of all, the vision. The vision certainly was the focus on children and youth, positive growth and development, and of course, in context to the family and school. So wanting to facilitate whatever we do, we didn't want to be reactive, but wanted to work in a way which actually brought systemic change, but also that would work for all children and youth. The importance of a collective impact of partners working together, and the ability to step up interventions without having children referred away, working together so there could be an increase in intensity when we needed it, the right service at the right time, at the right intensity, and in the right place. You'll notice at the bottom the concept of interconnected continuum support, and this is the notion that if we could strengthen not only working interdepartmentally but with community partners, with families across regions, our ability to step up without referring a child or youth away, but working together to increase intensity and then to decrease intensity would work much better. So our mission was to enhance service delivery to respond in a timely, effective, and integrative manner, taking into account not just the needs, but also the strengths of children and youth. And also at a regional level, for us to be able to respond quickly to barriers, because even when you put new structures in place, you may encounter new barriers, and the ability to be able to change, to refine our practices. Any conceptual framework you put into practice, when the rubber meets the road, sometimes new challenges emerge, and we need to be able to respond in a timely manner to those. And hopefully to promote the creation of an interconnected continuum support that integration of all services working from not a systemic point of view, but from a child-youth family point of view, would guide us as we would step up, increase our intensity, and decrease intensity based on level of need. Some of the guiding principles. The first one, and I'm just going to go across, strengthening universal and comprehensive positive mental practice and providing responsive integrative assessments and intervention for children and youth. The notion of our school environments and our community environments were key. How do we foster practices which actually produce more well-being, that foster engagement, that set in stage flourishing opportunities universally within our schools, within our communities? And so that became an important aspect. We're not just providing service, but we're looking at the way in which we work together, the kinds of things that we do universally across our systems. So following somewhat the Pan-Canadian Joint Consortium for School Health, they put forward a model of positive mental health, and we've been involved with them for more than a decade. We actually looked at practices in school environments and community that would help us be more responsive to children and youth needs in a proactive sense. Second one is when we looked at risk and need approaches. In other words, we have children either at a secondary, tertiary level where there's emergent needs, is not just to respond in terms of specific problem areas to reduce risk or to address needs, but also in our assessment of a situation, of a family, of children and youth, is to look at strengths. And again, this comes back to focus on recovery model approaches, where we look at what are the kinds of strengths that we have here that can be engaged, both within our relationships, but also within individual children and youth. Third one, providing appropriate service intensity at the right time. And this means being able to be so closely aligned that we're able to step up together without imposing on a child or youth as they be referred elsewhere, that we actually have working committees and teams that are integrated to support the addressing of needs. When we step up, we can do that in unison, and when we also step down, we supported our environments in the same way. And of course, we talk about a commitment to engagement and empowerment of children and youth. Outreach and advocacy are absolutely critical as we move from a system paradigm to a child, youth, and family-focused paradigm. Some of the key elements when we were talking about implementation, first one was a shared service paradigm. Person-centered, strength-focused, importance of self-determination of children, youth, and families. And throughout the years of ISD and the implementation, and actually the ongoing expansion of ISD currently, has been when things are not working, we come back to a child and youth paradigm. We go back to the reasons for why we're working together, and really that shared paradigm is absolutely critical. The biggest part of change management was actually providing folks with not only a rationale, but the inspiration, the vision for change. Senior level government commitment was critical. Across 4 departments, at ADM and deputy level, there was a signed agreement for alignment of services. We need to have the strength of a policy commitment that we are going to bring change. At the regional level, we saw the development of interprofessional and integrative trainings for teams. Now, if you look at if you looked across just our departmental services, we have mental health and addictions, which service youth, typically in the community. If I'm looking back a few years, we also have education. We have guidance, school psychology, resource that serve children and youth. Within the health authority, we have occupational therapy, among other professionals that work directly with youth. Social development, we formerly had school social workers from social development, school family enhancement workers, public safety, we have probation, youth mentorship programs. So we have a whole line of professionals that before sometimes, well, not sometimes, but many times worked in silos, not only between departments, but within departments, separate programs that wouldn't necessarily talk to each other. So the notion here of actually bringing people together, developing team approaches where we would have interprofessional training together. Because it's one thing to have people coming together for a case conference. It's another thing to actually provide training, which actually a team becomes an interprofessional and integrative team. You'll see on the next slide, integrative child and youth teams. So with the training, we actually formed teams, based on, and you'll see at the bottom in the acronyms, ACT, Assertive Community Treatment, Intensive Case Management, and FACT team. We do a lot from flexible assertive community treatment teams out of the Netherlands. And this team is pulling together on the same team, reprofiling from departments, individuals that typically would work in silos, but putting them on the same teams and having them work within school and community spaces where children and youth are, which means a close working relationship with schools, with our student services teams at schools, as well as with professionals in the community. And the notion of an ACT team or FACT team is that within our team and our partners, we were able to step up without referring children and youth away to a new program, making them repeat their stories. We're able to increase intensity and then decrease intensity. Formally, when we talk about services, sometimes when we have a crisis, something happens, we tend to refer away to a program, and of course there are wait times, and things kind of unravel. The importance of having an interprofessional integrated team is that it has the capacity in the context to be able to step up its intensity and then to relax that and continue to journey with the family and youth. So that's just a little overview of the development of integrated teams. We call them child and youth teams within our school and community context and work closely with school and community partners in a FACT team model. Another thing about FACT teams is that not only do they look at areas of risk need, but there's a great emphasis on positive youth development and strength-focused strategies, which is a little different. And from here, we really draw on the engagement, the motivation, the positive assets that add energy and positive emotion within our context. You'll notice regionally integrated governances. Within each region of the province, across 4 departments, we have integrated governance model, which is made up of directors within each of those regions from the 4 departments. And this governance body not only provides oversight to integrated service delivery, but they also address challenges. So if we're talking about information sharing, or we're talking about having access to programs or services in a timely way, and we see challenges, the regional integrated governance has the autonomy and support from senior government, senior officials, to act in a way which reduces barriers. In other words, what do we need to do to ensure that we have an interconnecting support? How do we ensure access? How do we reduce barriers? And so the ability and agility of a regional governance group to do this is absolutely excellent. What we've seen in some places is where there's been challenges. It could be in a school environment, it could be access to a program, is we've seen the regional integrated governance teams actually provide answers to these in a timely way, which means we don't see gaps in services, and of course that means that access to the right service at the right time is given. Information sharing and common case plans has been another notion. Instead of having up to 6 or 8 different treatment plans that might be facing a family or a child or youth where there's complex needs, having a single common case plan for those more complex cases, and also ensuring legislation that supports the appropriate use of information, but also removes barriers for sharing information at the right time. And given that we've reprofiled new teams together from 4 departments, what we've done is we've considered a singular plan, a singular approach in the terms of having all of the perspectives together, but able to step up and step down with appropriate information sharing. And we can speak, if need to, we can answer some questions, because that was a big part, the information sharing policies and protocols. Elements, again, we'll move quite quickly. Interconnecting continuous support, the notion that as we work together, not just departmentally do we see integration of services, but we see all services within the community working together towards that vision of an interconnected continuous support. Healthy school and community environments, universal well-being and resiliency programs and practices, and also measuring those. We've actually, across several school communities, have looked at what are the well-being resiliency practices that actually transform, actually not only support learning, but also support well-being. So, and really efforts not just on service delivery, but on our environmental practices. And then finally, operationalizing monitoring and evaluation. One of the gifts of ISD has been the development of an indicator chain framework, which looks at what are the indicators of integration of services and to what extent are they really embedded. And this comes out of development of an instrument called the Indicators of Change tool, which was modeled after a study by University of Toronto called Toronto First Duty, which was used in integration of services with early childhood centers. We adapted that instrument, expanded it for youth mental health, child youth mental health, across 4 departments. So that's a tool that's continued to be used not only in guiding the implementation, but also for monitoring how we're doing in terms of our integration of services. I'm not going to talk a lot more about the interconnecting support. It's really looking at all of our services together. Sometimes when you think of the pyramid of interventions and we think of 3 tiers, we sometimes think of organizing our services according to 3 tiers, and so we refer between services, and that's where we sometimes see some gaps. The notion of an interconnecting support is that we are all part of the same continuum. We step up together. So if you're a school teacher who's working with youth with complex needs, you will have support from more intensive services as you provide services to that child or youth. So you have the sense of a community, a family working together in terms of services to wrap around, but not in an isolated fashion, but together more cohesively and interconnectedly. A little bit of the governance structure. At the working level, we have integrated child and youth teams. In addition, within regions, we also have an integrated clinical team, which comes alongside of child and youth teams when there's a need for more intensive consultation and support. So on the working level, we have integrated teams, reprofiled clinicians that worked in silos in diverse programs across 4 departments, now working together, and they are outbound as opposed to office-bound in school context, which really covers a lot of the needs, as well as outside in the community. At the regional level, we already talked about the importance of having a regional governance, so regional directors, that's called in some places the ROC, or Regional Operations Committee. And included as part of that is community connections with nonprofits, youth-serving agencies. And finally, at a provincial level, where the agreements are supported, we have a Provincial Directors Committee, which oversees and also provides continuity in terms of ensuring that the key indicators related to ISD are being carried out in regions, and that there is not a program drift, that those essentials are there, as well as if at a regional level there's some challenges, they cannot resolve an area of challenge related to access, then provincial directors provides another level of support in assuring that on the ground there are the appropriate policies and practices in place.
Yeah, just to add to that really quickly, in terms of the child and youth teams themselves, they are under the coordination and leadership of our regional health authorities. So we have a clinical coordinator for each child and youth team, and one team will serve a cluster of schools in one geographic area, and there is clinical coordination through the regional health authorities. So that is sort of where the structure. That's the top end of the structure for the team. So we always have that clinical support there. On the teams themselves, we may have guidance teachers from the education system. We have occupational therapists. We have public health nurses. We have psychologists, social workers. So a truly interdisciplinary team. Those would be the people who are full-time devoted to serving on that team and serving the youth cohort. But also, in times when needs are intensified, the team does not let go of that child. When there is a need for tertiary level services, whether the child is going into a group care situation or into hospital, whatever the situation might be, the people who are involved in those tertiary services will then, on a temporary basis, join the child and youth team. So as opposed to referring out because the needs have become more intensive, the psychiatrist or the physician or other professionals, a probation officer, for example, will join the team, so we keep that one child, one file focus.
Great. So talk a little about the initial pilots. We always shy away from the term pilot because there are so many pilots. We have a history of starting pilots and really not carrying through. So by intent, we call them demonstration sites. So in 2010, we had two areas of the province, Charlotte County, which is in our south east corner, and northern part of the province, the Acadian Peninsula. We implemented one full region in terms of having child and youth teams, following the ISD model, one in our Anglophone and one in our Francophone framework. So that's where we started for the first 3 years with a targeted evaluation. And as again, it was we were at this time part of the Health and Education Research Group, providing the framework, and the Centre de Recherche et Développement en Éducation from University of Moncton carried out the evaluation concurrently. What we'd like to do is just spend a little bit of time looking at some of the outcomes systemically, and Patty and I will share this back and forth as we go into our last couple of minutes. First of all, did it make a difference in terms of children and youth? And so we had, of course, pre and post screening that was done, looking specifically at areas of internalizing and externalizing concerns, using acrobatic scales, reflecting experience of youth, but their teachers or workers, as well as parents. And what we saw coming forward on was actually decreases in internalizing, externalizing concerns, as well as increased adaptation as we looked at how children and youth were doing. And as we moved through this as well, satisfaction response from parents also showed they were pleased with the services received.
So nationally, we know that about 20% of Canadian youth are affected by mental health concerns, but generally only 1 out of 5 youth who need the help actually receive it. And that would be 4% of the population. But in our demonstration sites, 12% of total youth receive treatment in the Charlotte County site and 8% in the Peninsula. And so we were seeing an increase on the Canadian average of the percentage of children who are actually receiving support. In our demonstration sites, in fact, those in those areas, the number of youth receiving services doubled.
Yeah. I think what was really kind of interesting is that if you think of being a mental health psychologist, for example, in a mental health clinic formally, you typically would receive a referral or a case would be opened, usually at a pretty intense level. Given that we now have moved folks with mental health-related expertise closer to our schools and community, and they're outbound, is that we saw youth being seen at earlier points. In other words, when things were not as intense, and the opportunity to do more proactive work. And what we saw was the number of children and youth in terms of outputs. We actually saw about almost double in terms of the number of children seen. And when you think about that for a moment, it's a little easier to conceive, because if I'm in a school context and I know there's been a concern that's emerging with a particular child and youth, and I'm able to consult with the teacher or provide some recommendations to support or do a parent meeting, I'm responding early as opposed to later. And it could be that I'm going to touch base. I may see a child or youth in the hallway or touch base with a parent by phone, and suddenly that point of connection is taken on earlier, and I may actually see more children and youth. We know when children, youth, and families are asked to displace themselves to office-based appointments, what ends up happening is that many don't show or don't come or don't feel comfortable in engaging, and we see some significant attrition rates. So what we saw here was actually a greater number of youth being seen, and a decrease in what I would say would be dropouts or attrition as we go. Also, our waiting list decreased. In fact, in some regions, what we saw was the waiting lists were obliterated. Some they were reduced substantially as we move through. We also saw that was done with in terms of gathering data, was operational reporting that was done across the regions, looking at where they spent their time. And what we saw was actually greater involvement in at an earlier point, as opposed to waiting, saying I did 3 sessions. They were involved in a variety of different outputs or operational approaches, which could be group work, it could be proactive calls, it could be meeting with parents, it could be meeting with children and youth individually. But what we saw was actually an increase in more client-focused sessions at earlier points.
Yeah, and this was a really important process, creating that operational reporting template, because we were moving really from a caseload model where every clinician would count their caseload to something where it was actual activities and direct service and consultations and all of those things that are happening within a more accessible service system, and being able to track those and see that so much more was being done with those same hours in the day. So the provision of timely and coordinated services, they're seeing kids much earlier, as Bill said. Time periods for accessing services were much shorter. Linkages between, this was an important one, between our child and youth teams and school-based student service teams provided potential for clinical consultation, prevention work, just those collaborations that come from being part of the same team. And in fact, every student service team in every school in our province has a sitting CY team member. So one of the members from the team for that cluster will sit in on every student service team meeting, so that interdisciplinary viewpoint, that opportunity for consultation is there.
Yeah. As Patty mentioned, one of the unique attributes or characteristics of the ISD model is that with the interprofessional teams in every region, they serve a cluster of schools and the community regions that surround those schools. And a great point of contact is having a child and youth team member sit as part of, and it's not just a consultant role, it's being part on an ongoing basis of the discussions that not only talk about individual children and youth and families and engage them, but also the environments in the school and community. What are the practices that make a difference? Another area which is really interesting is that when you bring people together on a team, and in the formerly they would have worked individually, is that you reduce isolation among members of the team. No longer are you working on your own. You're working with others. There's tremendous expertise within teams, and also between teams. So if you have an individual which has expertise in neuropsychology that's on a neighboring team across regions, you can access from across regions that expertise. You can bring people in at different points because there's a connectedness. Interprofessional training then has the opportunity to be done across disciplines and across departments. So we're doing a better job of actually targeting training needs, but also providing greater resources from across departments where we were once more siloed. Again, we're just skimming the surface, but as Patty gave a story at the beginning of a family which really wasn't sure where to turn, how to begin process, how to get people to work together. We have one more story here, and I'll just read it as it is. Parent story following integration of services. Sometimes our narratives hit home the changes more than even numbers. We've had long-term concerns about our son's mental health. He's been missing a lot of time at school, and we are concerned that he may be falling in with the wrong crowd or even experimenting with drugs. We shared our concerns with a close friend who's a teacher at the school. We were so surprised when she told us that she knew how to get some support. Through the student services team at school, we learned about ISD. Almost immediately, we had someone from the child youth team reaching out to her son and supporting our family. We've been trying to get support for our son since he's been in elementary school. This is really the first time that we feel there's some hope. People seem to be working together to help him stay in school to understand his problem. Even our communication at home is better. I guess we're feeling hopeful. So as we go, just talking currently where we are, so we're going to talk here, Patty, I'm just looking at fundamental shifts in service philosophy and the structure organized. Okay. So I'm jumping ahead here. So in the last 2 years, what we've seen in New Brunswick is an expansion of ISD. We had our first 3 years of the pilot or demonstration sites. We had our evaluation. We've had some changes in government. But then the impetus to move forward, saying we're going to do this across provinces. The 2 demonstration sites said we're not going back to how we used to work. And then, of course, the motivation to move across the province was undertaken by senior officials. And even though we've had changes in government, the expansion's continued. So in the last 2 years, we've had a phased-in expansion. We're now fully running. But like any new structures, you may have structures in place, but it takes a while for people to catch up and to move from old ways of doing things to new paradigms, new practices. And that has led to the need for development of standards of practice. Within the framework, there were standards of practices or things that guided it, principles, and now we move from the notion of just principles to actual standards of practice. And that will provide opportunity not just for audits, you know, when we look at how we're doing across regions, but they'll also provide us with benchmarks to say to what extent are we following according to the model. There's always opportunity for regional differences and strengths and so on, but the core of ISD, what are the standards that are critical for guiding us where we need to continue working? And so standards are divided into 8 different areas: provincial leadership, regional governance, and this goes. It involves 2 parts. First of all, do we have the essential structure in place, the body that will help coordinate things, and also are we practicing in a way that's consistent with ISD? So for provincial leadership, our structures in there involve a senior ADM committee as well as a provincial leadership committee and practices associated. You go down to regional governance. We talked about regional governance committees that troubleshoot challenges to access. We talk about service orientation and guiding principles. Are we still maintaining a strength-focused approach, child and youth family-centered approach, equitable practices, understanding of First Nations related concerns and strengths and so on? Are we working towards an interconnecting continuum of support, both within our 4 departments but across? Service access. Are we nimble? Are we moving quickly to access? We really traded in our notion of referral to the word of access. How do we facilitate access? Our child and youth teams, how are we functioning? Well, we've gone from 4 departments now to reprofiled singular teams that deliver in schools and community and in collaboration, but are also overseen by the health authorities. How is our child and youth team in ESSD collaboration? And we just finished a review, actually, of our child and youth teams and our educational team collaborations. And we have areas that are working very well, and we've got areas that continue to need to be worked at based on our standards. And of course, engagement and participation, youth family advocacy, youth voice, self-determination, human rights related concerns, things that are just critical for us to remain child, youth, and family centered. The monitoring of ISD standards, you'll see that we do it based on a stages of change model, moving from non-implemented to fully implemented. And through group consensus or team consensus, we review these together. So when we look at standards, we take a hard look. We discuss with all 4 departments and community departments where are we in terms of our standards of practice, and we have consensus ratings, which gives us actually regional plans for enhancement of ISD services. It's dynamic, it's continuous in terms of monitoring and change. So this gives a sense of some of the essential structures that you'd find for the Interconnecting Support. If we go on to the next one, you can see how we have various practices and to what extent are they implemented. Not implemented planning. If you're familiar with ACT teams, you'll see a kind of a similar kind of approach when it comes to fidelity of practices. And anyway, we are now sitting at about 51. So we have exhausted our time with a very, very quick overview of ISD, but also there may be some questions, and we certainly on the next few minutes are here to see how we can respond.
All right. Well, thank you very much for that presentation. I mean, you talk about a quick overview. I mean, that was incredibly detailed. I mean, there was a ton of information to digest there. So great work. I mean, really incredible. I just had a question about, it's really a story of like it's not you didn't really create anything sort of new from clinical treatments and all that. It was about leveraging best practices that existed elsewhere and seeing what everyone else is doing that works at the best, and then organizing it around teams and around focusing on working across ministries and building that structure that in the end there you've identified, you've laid it out as a standard of practice that involves everything from provincial leadership all the way down. I mean, it's really quite an amazing sort of structure, but that's really the hard part. Is it's not the clinical practice piece, it's the organizing it and working across ministries and the partnerships and all of that. I'm just curious if I've assessed that right, and what, I mean, it must have been driven right from the very top of the ministry in order to make this happen in the way that you've presented it. Is that correct?
There had to be the senior leadership here to say, yes, we will move in that direction. The reports certainly and the recommendations certainly pointed to the need that we can no longer continue. I mean, these are human lives. These are children and youth and families who we value in our province, and we need to do a better job. I mean, I came from the Department of Health as a director in the youth treatment program in the 90s to the University of New Brunswick, and certainly not just our expertise was involved, but our heart was certainly in this initiative. I think one of the things that does make it a little different from what I've seen maybe across both national and international areas is that the reprofiling on single teams. In the 90s, we put together collaborative teams across the province, but we remained in our silos. To reprofile teams, to have interprofessional teams that are functioning as singular teams within regions connected to our schools, connect to our community environments and our outbound is a little different than remaining in silos, maybe meeting for a case conference. And it does take a tremendous paradigm shift. And when I think about, I think where we saw changes in people's personal view and practices is when we came back to our paradigm. Why are we doing what we're doing? What drives us to make differences? And I'd say one other unique characteristic, which I think really didn't come forward until we started implementing, was the importance of regional governance. So this is integrated governance across departments, which has the ability and support from senior level officials to be able to troubleshoot policies and practices that didn't work, that interfered with access. And that was tremendous when you see integrated teams saying, we need to function differently. We have some specific needs. We need to develop integrated services towards family enhancement because we're seeing needs in that area. To see a team at a regional level across departments utilize shared approach to funding and delivery and goodwill to work together is amazing. So the regional governor's part is critical because we still have 4 departments, but the way we work or the way they are working at this point is different. And it's not without challenges. We probably could talk another presentation on challenges. Anyway, that's short. Bill with us?
There, I didn't even remember to unmute myself. But I'm just curious. I mean, you've gone so far, and had this entrenched in standards of practice and that sort of thing. You've had a number of changes in government within the province. Do you feel that that's going to affect this program in any way, or do you feel this has become so entrenched that even changes in government aren't really going to be too worrisome for the program?
We last month actually had our 5th change in provincial government since ISD was first conceptualized. So it's always an emotional roller coaster to wait to see what's going to come down, especially in the first couple of government changes where we were really just still getting our feet wet and not entirely sure whether this had become embedded. At this point, it would appear that our service delivery mechanisms themselves and the people involved with them have said clearly we would not go back to the way things were before. The other thing is that we passed legislation in 2013 to allow for information sharing among child and youth team members, so that is entrenched now in our legislation for the province. And so there's no need to go back on that. So although ISD will evolve and things will shift over time, I think the notion of integration and working together and keeping children and youth and families at the center, I think that's here to stay. It's quite gratifying.
That's good to hear. You've mentioned teams as critical in this. Throughout this whole presentation, you've talked about the various ways that you've managed the working in teams, interdisciplinary teams, and integrating teams, et cetera. One of our attendees had a question about how you maximized, or have you been able to successfully maximize the scope of practice for each interdisciplinary team member within this model. Has there been a strategy around ensuring that teams aren't too hierarchical and are maximizing the different professionals that are part of these teams?
What a good question. When we first started ISD and demonstration sites, we had a delivery of training on interprofessional teams that was fairly extensive, and it was delivered as you would think in most sessions where you had you had someone leading that from outside, and so on. In the most recent reiterations of the team training, we've actually taken a more group process approach. And the leadership, the clinical coordinators for the teams, have been the facilitators of that training, but in a group process format, which means getting to know your team members, getting to know their areas of expertise, getting to know how we work together, how we support one another, what it means to be part of a team that actually can increase its intensity and draw on, as a clinician, you may be a primary on a particular situation for a family or youth, but you're not there alone. You have the support of other team members who can go with you and support you. So that fluidity of being able to engage, first of all, understand, engage, and feel the support for having others, and at the same time, not asking people to compromise scope of practice or areas where they need to continue to develop, but to have the strength that comes from really understanding. And I think the change in moving from a more typical training approach where we tell you what to do to a group process approach facilitated by the clinical coordinators. And doing that across teams, so teams come together and have a sense of even a larger sense that within our region we have 6, 8, 10 teams, and we have clinical coordinators. We come together, we do shared professional development. All of those things really assist to increase longevity. In other words, we see people staying on longer within teams and also working well together. So I think it's a great question. We still have some hurdles to get over, I think, in terms of how we work, and especially we work across school-based student services teams and child and youth teams and negotiating those relationships. But I think the group process part is absolutely critical. A team is more than just a collection of its individuals. It is an entity that grows and develops as a community does.
All right. We're just about out of time here. We did have one other question. They're asking, you mentioned the indicators of change tool, and they were just wondering if it's available for use in research at other universities or in other provinces.
Yeah, we've absolutely. To be honest, through the Health and Education Research Group at the University of Brunswick, and if people need to connect with us there, it's herg.ca. We've used it as a research tool, and right now are working on some publications with it at the same time. But yes, we would love to see some collaboration. Certainly, it reflects a New Brunswick context, so it would need to, you make the adaptations depending on your context and your focus. But I think really it's, and again, I go back to Toronto First Duty to say the ideas on how we began, following that format was there, and McCain's Family Institute worked with us on that. So we're really pleased. We'd be
happy to share it. So if you wanted to contact us, Doug has our emails, and there's the HERG website that Bill mentioned as well, herg.ca. But we'd be happy to share the tool if people would like to have a look. And as Bill mentioned, tweaking it to make it accessible for your own context.
All right. Thank you very much. Yeah. And if anyone is looking to get in contact with Bill and Patty, just let me know, and I will certainly pass you along. All right. So with that, I think it's time to wrap up. We are out of time. So, Bill, Patty, any final key messages or closing comments you'd like to leave the audience with before we sign off here?
Yeah. The only other thing, if you wanted to go farther looking at ISD, the document called The Story, which I think you have access to or was posted, I'm not sure. It's called The Story of Transformation of Youth Mental Health in New Brunswick. It's posted on the New Brunswick Department of Health website, and we also could send out, but it does detail, it's a long read, it's 50 pages, but it details the story of ISD, and I think for policymakers and those that may be interested in research in the area, it gives a good detailed framework, goes beyond what we've done in today's presentation.
Well, with that, I think it's a great place to sign off here then. So thank you very much for the great presentation. Great work. I mean, really an excellent model of collaboration that's required. We've gotten to that point where we know that working in silos isn't working anymore, and it's just about overcoming that and working together and collaborating and across ministries and across professionals. And I think you guys have demonstrated that you've done a really great job of that. So thanks again for sharing that with us.
Thank you so much.
It's a pleasure.
All right. So we do our webinars every Wednesday at 11 a.m. Eastern Time, and it's always great when you can watch live, as you do get to ask your questions and contribute your comments, and that really enriches the discussion. But when you can't watch live, we do record these sessions and make them available after the fact on our Knowledge Exchange Network at Ken, and of course, remembering back to our change in name, and that also means all of our websites and everything else have changed. It's now Ken, KEN.childrenshealthcarecanada.ca. That's where you can find all of our recordings and as well as information about upcoming webinars. And speaking of upcoming webinars, our next webinar will be on December 5th, where we will be exploring pediatric disclosure of medical errors, saying sorry when bad stuff happens. And for that, we'll be welcoming Dr. Donna Collar and Dr. Sherry Espin from Ryerson University in Toronto, and they'll be sharing some of their findings from 3 studies within a program of research on disclosing medical errors to 2 pediatric patients. And following that, on December 12th, we'll be showcasing one of the award-winning teams from our recent conference, from the Poster Fair. We had 2 poster winners in the 2 categories, and for the December 12th webinar, we will be welcoming the team from Stollery Children's Hospital in Edmonton to join us to talk about their research related to neonatal telehealth and how they're improving care for critically ill neonates in rural Alberta. So some great stuff coming up in the next few weeks. Thanks again for joining us today, and hopefully we'll see you back here in December. All right, bye everyone.
Bye.